Okay, so today we're going to talk about migraines. I read an article last week in the ESPN, which we'll talk about Steve Kerr's famous basketball coach, and it reminded us that we haven't done a talk upgrading our understanding on migraines in like 3 years or something like that, maybe 2.5 years or something along those lines. And things are happening all the time to enhance our understanding of this. We treat migraines pretty successfully here. I was just asking Dr. Gates that, when was the last time we had a migraine thing improve substantially or resolve? And it's quite some time ago. If I say how long ago, we'll probably lose all credibility. So I won't tell them how long it's been, but it's been a long time. We do pretty well with migraine cases. And so, and we don't want to, oh, by the way, okay, so I'm Dr. Martin Rutherford. I'm a certified functional medicine practitioner here in the state of Nevada, at the foot of the Sierra Nevada mountains, real close to San Francisco and Oakland, where our Golden State Warriors play. And I'm also a chiropractor since 1979.
Randall Gates, board certified chiropractic neurologist, as well as a chiropractor.
And so, as fans of the Golden State Warriors, we thought we might reach out. Really, what we're doing is updating our migraine presentation. I did read this article about a week ago on ESPN, and it talked about the suffering that the coach of the Golden State Warriors is having. For those of you who don't know who the Golden State Warriors are, even if you're not a sports fan, you must be living under a rock. Okay, they've won 73 games this year. They broke all the records. They got the craziest player named Steph Curry in the history of the world. They got this coach who's taken them, who is a phenomenal coach, who made the shot years ago that most people don't, well, a lot of people remember, for Chicago. Anyway, so we're sports fans here, and we are kind of a sister city to Sacramento and San Francisco and Oakland. Okay, so so this is Steve Kerr, Golden State Warriors land. So we just thought we'd cover a couple of things. So I saw in the article, Mrs. Kerr, if you do ever see this, that you were looking on the internet relative to migraines and what could help your husband. Any of you who have watched this for the 120 hours we've been doing this, no, we're not salesy. We're just letting you know there's a solution, and we're not saying that cavalierly. You're welcome to listen to this and see if what we say makes sense. And so we're going to talk about migraines, and we're going to talk about, we have these new data. If you look at it, they actually talked about a new type of migraine called new daily persistent headache. It has all of the features of the types of migraines that we treat.
And it can be associated with tension headaches too. And
can be associated with tension headaches. And it has all the triggers that we see come in and so on and so forth. And it's always interesting to me that we think it's very rare, according to the literature. And it's always interesting to me that we think that there's some new physiology that has come into the human anatomy that's been around for like about 2.5 million years or whatever it is, or 250,000 years, or whatever they argue with. Okay, there's all kinds of arguments on that too, but there's not. There's certain things that are consistent in physiology that alter physiology that cause certain symptoms, and this has all the hallmarks of migraine. So we're going to do a migraine talk. So we're going to do a migraine talk, and we will allude to and talk about the new daily persistent headaches and why we're pretty certain that they fit within the framework of the classic migraine, which, by the way, classic migraines are also something that are kind of considered not manageable in the medical world, unless you're talking about pharmacology.
Right. Yeah, exactly. Okay. Yeah.
So let's go. Let's do a quick overview. That was kind of a semi-overview. We're going to talk about why you might not be getting better as a migraine patient, and we will certainly talk about the one with relative to new daily persistent headaches, because Mrs. Kerr's wife, Mr. Kerr's wife, I think it's Margot. If you ever see this, the paragraph in there said you were searching was the paragraph that kind of initiated our talk this week relative to, man, we should do a migraine talk again and kind of update it and let people know what's going on and what can be done and so on and so forth. So migraines.
And I think I'm going to go right into NPDH.
Oh,
then
wow.
We'll dovetail back to migraines.
And let me just say this, okay? Dr. Gates is a board certified functional neurologist. That is no small feat for those of you who are not aware of it, which is probably most of you. It's a very rigorous postgraduate course, and they are certified by some of the same certifying boards as the medical field would use to certify their
board certified chiropractic neurologists.
Their doctors,
right,
yeah.
Exactly.
And when Dr. Gates got here, his main, I would say, the main areas that you were substantially, that's me saying that, okay, conversant in, was dizziness, vertigo, balance, migraines, and maybe concussions.
At that point, not as much, but
okay.
yeah, when we talk about like really focused.
So the point is, we've been on this for a long time,
right?
At least 7 years we've been working on these things. So if you want to go off into that direction, then go off into that direction.
Yeah, absolutely. So as a board certified chiropractic neurologist, what we do is term functional neurology. So we're not using medications. We're looking at the brain from a different perspective. So when you go to your neurologist and you're talking to a headache specialist, they have a list of medications that they're going to use for your type of headache. And if one doesn't work, they're going to switch to another. If that doesn't work, they're going to switch to another. Or they may go to like Botox injections. Whereas our perspective is to look at, okay, what is the underlying cause of the headache? And then how can we initiate a natural treatment based on what we know for patients who have these headache disorders? And fortunately, we've been pretty successful with the properly selected patient. This doesn't work for everyone, but we have a way of screening patients to figure out if we're going to be able to help them or not. So that's kind of the background data there. And then relative to new daily persistent headache, this is a type of headache within the International Classification of Headache Disorders. Number 2, guidelines. So that's the technical term for it. And a lot of neurologists are actually questioning the guidelines in terms of them being too restrictive for diagnosing this type of headache. This type of headache is different from migraines and tension headaches in that a person within 3 days will have an immediate headache, and then the headaches will continue. And it can have migraine qualities. It can also have tension headache qualities. But the difference is most migraine patients, it kind of comes on slowly, or it starts and it stops, it starts and it stops. Same with tension headaches. This has an abrupt onset, which is the characteristic feature of what we're talking about today. Now, in regards to this, 50% of the time, they don't really know the cause. 50% of the time, it just seems to come on. However, other times, 22% of the time, it comes on after a viral-like illness. Approximately 7% of the time, it can happen after surgery, or excuse me, I think it's 15% of the time it's after surgery. And then 7% of the time, it could just be to other circumstances, like they put you on progesterone for your hormones, or they put you on a different medication for a different condition, or you're exposed to toxic chemicals. So there are a number of different triggers, but it's interesting that surgery and infections are some of the most commonly linked problems to this subset of headache. And with that, we're going to dovetail into migraine pathology and kind of link these two together.
Okay.
Go ahead.
And in functional medicine, basically, functional medicine is separate from functional neurology. Okay, functional or whatever,
right.
Chiropractic neurology, but they both work with function. In other words, there was a point in time we have 130 million chronic pain patients in this country right now. If you're a migraine sufferer, or if you are a new daily persistent headache sufferer, you're one of them. Okay, and we have found that there is a consistency among these conditions that don't allow the body to resync and fix them, because trust me, your bodies are trying to resync and fix you as we sit here. And one of the things that we had to do, I do the intakes now. Dr. Gates said that we do a screening process, and I do the screening process, okay, to make sure that we're accepting patients that frankly can do this. All right, patients that can make the changes that need to be changed, or disciplined enough to do the exercises that we're going to tell them to do. And there could be other things, but in that intake, we've had to develop a history that is relevant to the chronic pain patient. Many of you are getting histories and testing for the acute model of pain. In other words, I've got an infection, I take a drug, the infection goes away, I'm fine. But the drugs don't get these to go away, so you have to keep taking it. So our point was, what did we have to do to figure this out? We had to develop an understanding of chronic pain and a history of chronic pain, which leads to the fact that we had to understand that there were certain clinical pearls that we would understand by doing a verbal history that meant certain things. For example, abrupt onset and triggers. The first thing that we noticed in looking at new daily persistent headaches was that they had the same triggers that we see in all of our chronic pain patients. For me, I had fibromyalgia, okay? Overwhelming infection, viral infection. Many of the patients come in here after a surgery. Many patients come in here after a trauma. Many patients come in here after a immediate or long stressful period of time. I'm sure is relative to Mr. Kerr, I'm sure that being an NBA coach is not stressful at all. So I mean, so usually what we find in the histories is that there was almost kind of a setup beforehand. Right. Then they have, and I believe it when in Coach Kerr's situation, I believe it was a back. He had a disc problem or something like that.
Yeah, disc herniation.
And he had a disc herniation and he had back surgery, and boom, there it is. That is like, we hear that like every day here. I had a hip surgery, and the next thing you know, I got peripheral neuropathy. I had a shoulder surgery, and the next thing you know, I got fibromyalgia. I had another surgery, and the next thing you know, I got migraine headaches. So, so just to kind of lay the groundwork of those of you are going to say, well, the testing isn't there. The MRI was normal. The CAT scan was normal. They don't know what's going on. The cerebrospinal fluid leak is okay, which was mentioned. It was in the newspaper, so I'm not violating anybody's rights. Exactly. Okay, was what was thought to trigger it. Now that's okay, and now it's still there. And so this history to us, and I hope I'm not taking like a thunder away, would indicate that we possibly triggered an ongoing immune system issue.
Absolutely.
Does that like go too far ahead of what
it doesn't go too far ahead at all.
Okay, no, cool. Absolutely. So, and I'm talking specifically to migraine sufferers, but at the same time, it's the same model for new persistent daily headaches, and the understanding of both are not there in the medical model. And we are not anti-medicine, okay? I think we've said that every single time, because we're looking for a bug or we're looking for something that is not the issue. The trigger now is gone. The viral infection is not the issue. The surgery is not the issue. What's the issue is what's there now. And that's what Dr. Gates is going to go in somewhat detail.
Yeah, exactly. So let's look at a migraine and how it works. Think of dropping a rock in a little pond. And when you drop the rock in a pond, you get those waves of ripples of waves going out into the pond. We've all seen that. You get a little one, or you get a big one, and smaller ones after that. In essence, that's what happens with a migraine. So you get an area of inflammation in your brain. You don't get enough blood flow to that area of inflammation. And as a result, you get this thing called cortical spreading depression, which is just like the inflammation creating a rock that dropped in the pond. And you get this spreading wave of lack of activity, so to speak, in your brain. And that can be associated with high levels of inflammation. The technical word there is calcitonin gene-related peptide, CGRP. We'll just term it that, inflammation. And with that, then the inflammation builds, and you can start to get pain associated with that. You may then have a rebound of trying to get too much blood flow to the area, which you can feel as the pulsating. They call it hyperperfusion. And that's a migraine in essence.
So and this information that Dr. Gates just reviewed is in the literature.
Oh, it's all the literature.
And it's attached.
Yeah.
And we're going to have to start telling them where it's attached.
It's attached. Yeah. All this information is attached on powerhealthtalk.com. So if you go to the broadcast there, we have 31 articles attached to today's broadcast to demonstrate everything that we're talking about. And this phenomenon I described to you, this is a 60-year-old model phenomenon. Like they knew it 6 years ago, and it's still the same model going on for migraines. But a few things have changed. And the medical approach is to use, sumatriptan, so drugs like Imitrex, in order to change the blood flow parameters to the brain. We also have a bunch of other medications that have come out. We have Botox therapies because they found that with migraine patients, you get these muscle spasms. So you use the Botox, it shuts off the muscle spasm, which changes feedback to the brain in terms of the muscle hypersensitivity, and that can help migraines. And these are the current standard approaches for these types of headaches. But what we're now finding is that in order for you to have this, what we term cortical spreading depression, you have to have immune system activation in your brain for that really to happen, which is a big deal. So we've talked in other broadcasts relative to concussion and memory problems that the new literature is talking a lot about the brain's immune system. The brain's immune system are termed microglia. They're separate from our immune system in our body because they have to be highly controlled. So if we have inflammation, they don't get too overreactive. Or if we have an infection, that they take care of the infection right away, but they don't, again, become too overzealous in their attack on a bug. What we're seeing with migraine patients is that these microglia are activated too greatly and they create inflammation themselves. And then as a result, that perpetuates the migraine process. We're also seeing that the blood-brain barrier, which is basically formed from the blood vessels going into your brain, they should be like a tight pipe. Rather, they look like a PVC pipe with a bunch of holes in them. That's what it looks like for a migraine patient. So the problem there is that inflammation in your body can now go into your brain and vice versa. And so then there's inflammation in your brain, and then the microglia in your brain, the brain's immune cells start going to the blood-brain barrier, and they can actually cause more leakiness to the blood-brain barrier. We highlight this because as we both came to the same conclusion when looking at new daily persistent headache, is that infections and surgeries really seem to predispose people to this problem. And there's even research now demonstrating that you can have high levels of inflammation in the brain with new daily persistent headache. And when you get a surgery, think about a surgery, they're going, they're cutting your tissues open. There's going to be inflammation associated with that. The anesthesia is argued to influence the immune system. It can deplete the body of this important product called glutathione that calms down inflammation. It eliminates toxins from the body. And so it's not surprising to us that those are the two main factors being associated with this type of headache that was mentioned for the world's greatest basketball coach at this point in time in that article. So that's why we feel this is exciting relative to the new daily persistent headache sufferer. And just know that with new daily persistent headaches, these well-meaning doctors, they're grasping at straws because they don't know what to do. Because in their model, and this is how it's
this is
termed,
key.
This is how it's termed. They'll say, well, if a new daily persistent headache sufferer has symptoms of tension headache, then we need to give them tension headache meds. Or if they have symptoms of migraines, we need to give them migraine meds. But then in the same research articles, they'll say, but we know that this is futile and it doesn't work. so people are just trying things. They're just, shooting arrows in the dark for these patients, which is not a bad thing. But that's why at this point, I think it's 77% of new daily persistent headache sufferers are told that their problem is going to be chronic and you're just going to have to live with it for the rest of your life because we have no other solutions. Unless you're lucky enough to be in the 15% where it will go away after 3 months, which I think we're past that timeline. And then, or the 8% that are relapsing.
Yeah, he missed the first, I don't know.
Yeah.
Maybe 30 games of the year or something like that because he had to have back surgery.
Right.
Yeah, so it's been a while.
Mm-hmm.
Yeah.
So that's really the skinny on this.
So, okay, so there's hope. Okay, so there's hope. So these types of conditions can, most of the time, they cannot be cured. Okay, because for those of you who are aware of immune conditions or autoimmune conditions, which I ran into a dentist friend of mine the other day we had a conversation at dinner about autoimmune conditions. So it's getting out there. Everybody's kind of aware of it. He's becoming more careful using antibiotics because of it. Anyway, it's a new paradigm. It's a paradigm that's right now it's difficult still for the medical community to embrace. Why are we able to do that? In the alternative community, I guess we're considered alternative, although we don't consider ourselves alternative. We have a little bit more leeway in being able to explore the literature and being able to try things clinically without having to do a 5-year study and then another 5-year study and then having a peer-reviewed journal article and then doing another 3-year study, and 17 years down the line, you can finally do something about it. Another thing is most of the time, these chronic conditions are related to kind of like post-traumatic stress syndrome. Most of the patients have some sort of a high stress environment that they're in that's perpetuating that stress and creating stress hormones. That doesn't help your immune system. Your immune system clearly is a big player. Your gut, if you any of those, if you've been watching us for those 120 hours, know that for us, so much starts in the gut. These are multiple vicious cycles. Brain affects gut, gut affects brain. Both of those affect the immune system. And there's more other issues that tend to come involved, can tend to become involved. But those are complex, interrelating, multiple vicious cycles. Once you understand which vicious cycle you have to enter into, then you can go forward. And the beauty of it is, the vast majority of the time, it can be done without medication. And we work with medical doctors, and certainly we have patients who we need. We actually have an osteopath who's kind of part of our staff. He's part-time. He comes in a day and a half a week. And when we need some medical intervention in a specific case, he's here, but it's minimal. Another thing with these cases is less is more. Less drugs are better. Less supplements are better. It's kind of like the opposite of what most people experience. So there's a lot of nuances, though, to this condition that fit the 130 million chronic pain patients. The whole point is that this isn't some condition that just dropped out of the sky. It's a condition that just isn't yet fitting into the medical model. And so it's something that can be helped. We've seen it helped consistently. It's been a long time since we have had a migraine case not improve substantially or resolve. And so we feel like we have, we feel pretty certain in sharing with you what we feel is the data. A lot of people say it's the truth, there's a fact. It's the data. The data is out there. We've been able to apply, we put two disciplines together where the brain can be affected functionally by strengthening it, stimulating it, calming it down, so on and so forth. And then the chemistry that alters that, it was set off by the flu. It was set off by a surgery that caused inflammation, can be altered and calmed down functionally, most of the time without drugs. And then you put those two things together, and now you have a solution for an autoimmune problem, which essentially, that's what this is. This is essentially an autoimmune problem where Coach Kerr's immune system has kind of turned on him a little bit, and it's starting to attack tissues that shouldn't be getting attacked. That immune system gets calmed down, he feels a lot better. And any of you who are dealing with this feel a lot better. So that's kind of the English summation, or the clinical summation would be a better way.
Exactly, because with these autoimmune problems, when that blood-brain barrier breaks down, so if you have immune inflammation in your gut, it's going to go into your brain. It's going to activate more inflammation and more immune cell activation in your brain. You can go back and watch our concussion broadcast. That's the problem with concussion, because they're finding if you hit your head repetitively, however many times, 57,000 times, like they said, I think in the movie, relative to Mike Webster.
Yeah.
I can't remember the exact
concussion
number.
movie.
Yeah. But, you know, the number of hits like that an offensive lineman is going to take, well, that inflammation in their brain is there, and then their brain immune cells get turned on, and then any inflammation throughout the rest of their body will keep driving inflammation in the brain. So that's what's so confusing for people, because they have the trigger, like a viral-like illness or a surgery. Now they develop new daily persistent headache. They can't figure out why it's not going away, and it's because the vicious cycle has started. Now inflammation from the body's going to the brain. Some of the inflammation in the brain is just further breaking down the blood-brain barrier, and then you're stuck in this loop. That's what it appears to be at this point.
Okay. So that's it. That's really migraine headaches. We see new daily persistent headaches as a subset of that. Frankly, we see it as one and the same. And there are solutions. We have one other talk on migraine. It's about 2.5 years old. But you can look at our talks on blood-brain barrier, or our talks on autoimmunity, or anything like that. And to you, Mrs. Kerr, there is an answer for this. Any of you who have comments on us, now normally we don't take questions, because when we were in the beginning, it was just overwhelming us and so on and so forth. But if you want any data about any of this, you go to powerhealthtalk.com, and there's data there on how to get all of the research articles Dr. Gates just mentioned. There is data on there on how to become a patient. Now, we almost never, ever say that, okay? But in this unique situation, we want to make sure our coach is good next year if it's something that he wants to explore. Probably too late for the playoffs, but
Yeah.
Because it takes a little time, it takes a couple of months to get somebody through something like this. But it really was an inspiration for us to go, whoa, have we even done one on migraine?
Right.
And then and we only see migraines all the time. And then it was, oh yeah, it was like 2.5 years ago. So let's do another one. It's okay. So hopefully that's helpful to any of you who have been diagnosed with this new and rare condition. And hopefully that gives you a little bit of hope that there is something that can be done so that you don't have to be suffering with this for the rest of your life. All right.
Okay. Thanks for watching.
We'll see you next week.